introducing Dr. Rafael Fonseca from the Hematology and Oncology Department at Mayo Clinic in Phoenix, Arizona, who's discussing his article, The Importance of Economic Trade-Offs in Cancer Drug Pricing. It will appear in the August 2018 issue of Mayo Clinic Proceedings.
In this particular paper, we propose readers consider a couple of things that are important as we engage in this dialogue, in this conversation about the prices of medications. The main overview, if I had to say it in a very short sentence, is that in life there's almost always trade-offs. And that's really the point that we want to make with this paper, so that people consider what the trade-offs are when you decide on policies or regulation that would affect how drug development ultimately is conducted. Particularly, we focus on the prices of newer medications, patented medications. Certainly we do so because those are the ones that are more expensive, and those are the ones that are more hotly debated. Of course, there's a whole parallel conversation going on surrounding the proper pricing for generic medications. But we propose two things in this paper for our readers to consider. We propose, one, that there is a misconception that these drugs don't provide value. In fact, we provide the background and the data to support that these medications do provide value, both to patients as well to society. When we consider the price of these drugs, and I think we all rightfully are concerned and want to make sure we get in return proper value for the payment that is being made for these drugs, we need to estimate that somehow. In our paper, we talk about some of the metrics that are used for this measurement and some of the limitations associated with these metrics. Probably more importantly, and something you might not see in other publications, is the aspect of societal value. One of my favorite numbers to quote, and we discuss this in the paper, is if you had a magic wand that just tomorrow I could make cancer disappear, the net economic benefit for present and future generations of Americans would be $50 trillion. So just recently, for instance, the American Cancer Society showed that over the last 5 years, cancer mortality has dropped by 1.5%. May not seem like a lot, but if you use that same number that I just provided you, that's a net value of about $750 billion. So there's things that need to be considered. We also describe some of the other aspects that should be considered as we think about the value of these medications, some of which are hard to measure, to quantify, and to bring into an equation. Things such as the value of hope, the value of options, the ability of patients reaching certain landmarks in their life that are important, such as could be the birth of a child or a grandchild, participating in a wedding, and so forth. The second point we make, and I think this is pretty well documented in the economic literature, and that is that if you engage in practices that potentially limit the revenue for the development of drugs like this, particularly if we go as far as doing things such as price fixing, there will be trade-offs, and one of the trade-offs is that you stymie innovation. If investors don't see a possibility of a brighter future, in the case of drugs, it's high risk, high reward, you will find that there is diminished interest in funds being allocated to biotechnology and pharmaceutical development. Now, it's interesting, if you're a patient and you were to read this paper, I think it provides a perspective that just opens up questions that are not normally considered. What people hear is about the cost of medications, and some of these medicines are very expensive. Many of them, and in fact many of the ones that are approved over the last few years, routinely exceed costs on the list price of over $100,000 per year. Now, I won't go into all the nuances of how that number breaks down, because many of these numbers, one, they don't directly affect patients, and two, there's rebates that are applied to some of those medications. But when one just focuses on the cost, if the person is a patient, they might even sometimes express concern. Wow, this is very expensive. Is this something I should be taking? I think it's important that we all realize that the conversation we're opening with a paper like this is that there is in fact a value, and then this value is reflected in increased longevity. In the ideal world, that comes as well with increased quality of life and increased options for potential future treatments for patients. We've seen that over and over in history, where innovation can bring solutions that ultimately not only help people in ways that are tangible, that are meaningful, but also economically they're beneficial. Two examples are very simple. One of them is tuberculosis. 50 years ago, 60 years ago, we had hospitals for tuberculosis. We don't need those anymore. Why? Because of innovation that was associated with the treatment of that condition. More recently, two decades ago or so, HIV and AIDS was creating great problems for health systems, and we had limited options for the treatment of these patients. In fact, while in training, about a third of my patients that were admitted to the internal medicine service were AIDS-related complications. Well, fortunately, through innovation, we have better therapy for patients who have HIV and AIDS. The treatments can convert this now into a chronic disease, many of whom are never hospitalized, many of whom have near normal life expectancy, and that was just exclusively the consequence of innovation. And guess what? For HIV, we were also building structures and wards, and in fact, where I trained, we did build an extra ward for patients with AIDS, which I don't know what it's being used for nowadays. For the most part, the findings of our paper only relate to practice in as much as how we discuss options of treatments for our patients. I've been pretty clear and vocal about the fact that discussions about pharmacoeconomics do not belong at the bedside, and I think I would say fortunately the majority of my colleagues agree with that, but this is important to keep in mind. At the bedside, I think the physician should always be focused and exclusively be focused on those actions and decisions that are in the best interest of the patient, quite consistent with the motto of our institution. So our hope is to continue to engage in a dialogue that has by necessity to be multidisciplinary. I think physicians obviously are at the center of this, but this primarily is related to patients, so we need to be engaged in a conversation with patients. I have argued we need to bring to this conversation economists because they bring expertise to our field that we don't have, and yet they don't have the knowledge of the medical implications of what's being discussed. I think policymakers, payers, and others need to be engaged in this conversation now. This conversation is fundamental because, as I've stated before, we need to continue with this pace of innovation. And our goal specifically with this paper was just to project considerations that, in our opinion, are not routinely considered.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.